referential lymph node called the sentinel node, and from there onwards to subsequent or second echelon nodes. And during surgery, these can be removed by being detected by a probe, the radioactivity, and also they use some blue dye at surgery so that you can see the lymphatic vessel and the lymph node, which you see below. If you have such a combination, it's a very good confirmation that this is actually the sentinel node, because that is a very essential thing. In this new approach, one wants to base the entire treatment regimen on the finding on one or two lymph nodes. So we have to be very sure that this node is actually the one draining from the tumor and not from something else. Now initially it was simple. We started with melanoma and breast carcinoma. We injected some radioactive material, we got a hot spot, we marked it on the skin, and the surgeon cut it out. But after this became successful, then other indications appeared, and this was for tumors and also for drainage areas which were more challenging. Especially in the head and neck, and in the pelvic area it's more difficult. In this sense, the imaging techniques have developed, and especially SPECT have been found very helpful. And here you see in the past 5 years, this is my SPECT procedures in the department, and you see that the majority in green, these ones are in fact the sentinel node procedures. They are the majority of all our SPECT images. Well, for some indications, like, as I said, melanoma, breast carcinoma, simply draining to the axilla, it is not necessary to do a SPECT. But if the melanoma is located in more difficult areas, like in this case in the eyebrow, it's more difficult to see which is the sentinel node on the planar image here. And such an image is much more helpful for the surgeon because he gets the anatomical detail. And also here you see melanoma on the trunk draining to the axilla. That is simple, but there is also something quite nearby. And it astonished us to see that this lymph node was in fact a paravertebral, way inside, much further inside than the surgeon would have thought it would be. Also, we made these three-dimensional images, which is in fact just stacking the transaxial sections like that and then displaying them in a three-dimensional mode, which is also helpful for the surgeon, especially because he can sometimes better see how the lymph node is related to the muscle. Is it in front of the muscle or behind the muscle or a major vessel? Simple melanoma on the leg does not require SPECT, but for some reason they have done anyway. This is simple, but here's a better delineation by SPECT, and the 3D makes a very pretty picture. And by now we have treated the surgeons so well with this that they got so much used to this that if I deliver this image, which is sufficient, they call within 10 minutes, where's the SPECT? So they are getting used to it. Breast carcinoma is a bit more complicated. We always think of draining to the axilla, which is certainly mostly true, but there are always also other drainage pathways which are more difficult to localize, and here SPECT can be helpful. It's good to remember that we do a lot of this work in good cooperation with the radiology department. All our non-palpable tumors are injected with ultrasound techniques or with stereotaxis, and the radiologist does that, and I only inject the radioactivity because we all have our jobs to do. But this was actually the very first SPECT I made on a patient who did not have drainage to the axilla but to the internal mammary node, and see how much better this is displayed for the surgeon. again, here we have drainage to the axilla and some nodes here. Now these are internal memory nodes, that is not difficult, but this one, is it intramammary or is it internal memory or is it deeper, is it intercostal? Well, SPECT CT clearly shows that it is an intercostal node on its way to the internal memory nodes. Whereas here, nearly the same picture, only on the other side. You see drainage to the axilla, drainage to a node here, and from there to here. That one is clearly an intramammary node. Initially, we didn't know intramammary nodes. I've never heard about that in our pathology reports for breast carcinoma surgery. But since we do techniques like this, we see intramammary nodes quite frequently. And in this case, this is the sentinel node, not that one. That is the second echelon node. So if they remove this one and leave that one behind, you leave a potentially tumor-containing node behind. And this is why it's essential to localize it well. And here, this seems to be drainage to the axilla, but it is not. It's in fact interpectoral, between the pectoral muscles. You can nicely see it here where it is located. On planar, you could not make this distinction. It is this node. And you can see also that if you supply images like this to the surgeon, he may choose a different approach to this node. After all, I think surgeons prefer images like this to this funny nuclear medicine guy putting a blue dot on a skin somewhere and he just has to cut. So they're much more relying on this. Then occasionally we have non-visualization. No matter how long we scan, we do not see a sentinel node. In the past, I would re-inject the patient and re-scan. Nowadays, we do SPECT CT. And surprise, surprise, there it is. Also here, we do not see the sentinel node, but if we do the SPECT CT, we see that the node is in fact an interpectoral node behind the injection site. Here in the 3D image, which is tilted a little bit, you can see it better. Also, the site of the injection matters. Here are two tumors in a patient, but one was a benign one and one was a malignant one. When we injected the first one, we had drainage to the axilla. When we injected the second one, which were only 3 centimeters apart, and in the outer upper quadrant, so you would not expect drainage to the internal memory nodes, but it did. Nowadays, the indications for breast carcinoma have also increased. Multifocal tumors are now being targeted with the sentinel node approach. So we first inject one tumor and have drainage to the axilla, then we inject the one next to it and we have drainage to the internal memory nodes. Also, the technique is being used now in recurrent breast carcinoma. Not so successfully as in primary tumors, because something has happened to the breast, so the lymphatic drainage may have altered or have become impaired. But what we frequently see, that in a recurrent patient who had so-called radical lymphadenectomy of the, it's not so radical, there are still a few lymph nodes in the axilla there, but we see drainage to the other axilla, contralateral axilla. And that is then a sentinel node too. Nowadays, if we can visualize that, our surgeons like to go after this node and just be sure that it is negative. Here something else has happened, also surgical intervention. This lady had breast prosthesis and a lot of original breast tissue had been removed also, and only 7 months later she got an indication from this private breast clinic that, oh, on retrospect there was something wrong with the tissue they had removed. It was a carcinoma. So with great difficulty I have found it and injected it, but here you see that the drainage due to the extensive surgery, has also changed to a purely internal mammary drainage. And here you see the same in the 3D images. This patient similarly has an injection here with drainage to an intramammary node, an internal mammary node, and an axillary node. Here you see them. The same week, the patient also had PET-CT. This is the PET-CT. It's a three-dimensional image. The patient is lying on the breast support, which you also use for MRI. And you see the small tumor there. You see no metastasis. And this is the same image, more or less the same image, also 3D with these nodes. On surgery, it was shown that all three lymphatic stations were tumor positive. And it just shows that although PET-CT is very useful for diagnosis and staging and follow-up of breast carcinoma, for the microscopic disease in the lymph nodes, we still need the sentinel node approach. Moving to other areas then, head and neck is a particularly difficult area. This is the image planar, and here you see from an oral cavity carcinoma the nodes, in fact 3 sentinel nodes, and also the relation to the muscles in front or behind. Another one, tumor on the skin of the head, draining these. And here also unconcealed one. There's one sentinel node here, something faintly there also becomes a sentinel node, but there's one which we miss, which is, you can just see it here, it's behind this injection site. So there are 1, 2, 3 sentinel nodes, much better displayed here. It's and what you see here is not the patient's moustache, it is the artifact from the dental work. Penile vulvar carcinoma, we sometimes do it not so often because the drainage is relatively simple to the inguinal nodes, as you can see. And here is a patient with vulvar carcinoma with bilateral drainage. And on the 3D image, it's better to see which are the superficial ones and which are the more deeply located nodes. This is a penile carcinoma showing bilateral drainage and also something here. This is the injection site in the tumor. And here are the inguinal nodes and one in the midline. Sometimes there is a lymph node there in the midline, but in this case it is contamination. And here is a case of unilateral drainage to the right groin only, also from a penile carcinoma. There's nothing here. And the PET scan with FDG shows why there is nothing there. There's a metastatic lymph node there, which you also see here on the CT. Nevertheless, our urologists like to do sentinel node because, of course, this patient will require a radical lymphadenectomy of the left groin, but they will do the sentinel node approach on the right groin, hoping that it is negative, and that may save at least one lymphedemic leg. So the penile and vulvar carcinoma usually have simple drainage to the inguinal node, but for cervical cancer and prostatic cancer, it is much more complicated because those go to the lymph nodes in the pelvic area, which are various layers of lymph nodes. And if we make an anterior view planar scan, we may see these, but the ones in the back probably we will not see because of attenuation. Here you see an example of cervical cancer. Here's the injection with a drainage to an iliacal lymph node, but also one quite high up there. There's a para-aortic node, which is better displayed here on this is one of the old Hawkeye images, I think. And of of course, this is also quite essential to notice, because the same happens in prostatic carcinoma, that even if the surgeons would do a so-called extended pelvic lymphadenectomy, they would remove all the lymph nodes they find in this area, but they would never remove that one. Now, this is the most prominent lymph node where the tumor drains to, so the most likely one to be malignant. And these are, in fact, patients we see 1 year later on our PET-CT scan with a recurrence somewhere in the para-aortic area. The same we've seen in our series in prostatic carcinoma, that roughly 30% of the patients have sentinel nodes outside the area which is targeted for the extended pelvic lymphadenectomy. And 40% of them have pathological lymph nodes. It is clear from this planar image that the planar image is of little use. Very difficult to say on this image which is a sentinel node, and also useless to put our blue dot on the skin of this patient, even if we would know where to put it, because the surgeon would probably operate with a laparoscope and would not see our dot. So therefore the three-dimensional imaging is necessary. Here you see the planar image, and at several levels, here we see lymph nodes in the iliacal area. But here is also a high one, which is a para-aortic lymph node. And in the 3D image, you can see them more. These are in different planes, but here you see them all together. This patient, this is also interesting because here on the planar, you would wonder which are sentinel nodes. These ones, or here. But in fact, they are concealed behind there because they are quite posteriorly located. Only one, which we can hardly see, but it's probably this one, is way in front. Again, one which would probably not be removed. It's against the abdominal wall. It happened to be the only one of all these nodes which was tumor positive. Something else you see, something going through the funiculus, leaking from, it's an intra-prostatic administration, and some of the material is leaking via the funiculus. Then here, a similar situation. Planar image doesn't tell us much. On the late image, we see a number of dots. Probably we would say, this is a sentinel node, that is a sentinel node, that is a sentinel node. Wrong. The sentinel nodes are here, namely quite far in the posterior aspect. Also, there's a pararectal node. And this node is a contamination, but it's so in front, this is why it is so hot. And here, this one, you can localize there. Here we have testicular cancer. The drainage of testicular cancer is through the inguinal canal straight up to the level of the kidneys, and there we usually find a para-aortic sentinel node. And surgeons especially like to show that on the SPECT CT scan in relation to the major blood vessels there. And here's an example of renal carcinoma, renal cell carcinoma with a sentinel node located there in the para-aortic region, and the 3D image. And you see the surgeons at work here. During surgery, the finding of the sentinel node is facilitated by the use of a small intraoperative mini gamma camera, this thing. It is as big as a fist, and it is placed above the patient, above the abdomen of the patient, and the surgeon can see the lymph nodes like that. Also, the probe is fitted with a small ID125 source, and the computer is told that he should not showed it as a dot, but as a circle. So on our image, we will see the sentinel node, which is the technetium signal, and we'll see the iodine 125 signal as a circle. When the probe goes toward here, the surgeon just lines up the circle with the node. Then they take hold of the node and pull it a little bit. You see it move, and then they remove it, and after removal, you can check that they've really removed the correct nodes. So this is very helpful. Nowadays, there's also the possibility to do dual modality imaging with the technetium colloid using this mini gamma camera, and also with fluorescence. Instead of the blue dye, they now mix the nanocolloid, the technetium nanocolloid, with Indo-cyan green, and this stays. It has been shown that it stays very well in the lymph nodes, and with fluorescence camera during surgery you can actually see the lymph nodes light up. Because even though that the probe can detect the radioactivity, it's not always so easy for the surgeon to see what he really must remove. Sometimes it's very small, and if what he needs to remove can light up like that with fluorescence, it's helpful to the surgeon. And not only to the surgeon, nowadays 2 mm sentinel nodes are being removed with the robot. And my biggest problem with this technique is that where do I place this mini gamma camera between all these arms? So it's imperative that we try to provide the best possible images to the surgeon. And if we do this like that, we have a happy surgeon. And if the surgeon is happy, so is the patient. So in conclusion, the SPECT CT is certainly more sensitive and more accurate than the planar lymphoscintigraphy in locating these sentinel nodes, which is particularly true for tumors in the head and neck region, abdomen and pelvis, but also for non-axillary sentinel nodes in the breast imaging. And this may also influence the approach of the surgeon to these nodes. And all we can do is to make sure that both surgeon and robot do their work to the very best. Thank you.